This episode of Planted is brought to you by Pax Labs.
The Radio Misfits Podcast Network.
Hello, everyone, and welcome to Planted with Sara Pine. I'm Sara Pine, your host, and today's conversation is one I've wanted to have for a very long time. My guest is Dr. Donald Abrams. He's a physician, researcher, and a longtime leader in integrative oncology. Dr. Abrams has spent decades caring for patients with cancer and HIV and was asking serious scientific questions about cannabis long before it was safe or popular to do so. This is not a conversation about hype or miracle cures. It's about evidence, ethics, patient autonomy, and what compassionate cancer care really looks like in the real world. Dr. Abrams, welcome to Planted. I'm so glad that you're here today.
It's a pleasure to be here. Thank you.
Absolutely. So the first question I'd like to ask you that I ask all of my guests is, what was your first cannabis experience?
My first cannabis experience occurred in Cleveland Heights, Ohio, when I was in high school. I had a gang of friends. I lived on a street called Grenville, and we called our gang of 11 of us the Grenville Gremlins. And, you know, we were in high school, seniors in high school, and we were meeting in somebody's basement, and somebody said, "Oh, look what I have." And they had some, very low grade, we would consider today, cannabis. And we all, tried it. And I can't remember if I actually got off or not, but that was high school graduating. Then I went to Brown University, and I must say that cannabis was my entertainment of choice on the weekends. I would probably be a very different person today if alcohol was my weekend recreational. I mean, I did a little Boone's Farm apple wine for sure, but
I remember that.
Yeah. And then I went to Stanford Medical School and again continued using cannabis for relaxation and recreational enjoyment.
Yeah. Oh, it is funny because when you think about, especially like in college, and even I know for some more precocious youth in high school, there's a lot of prevalent alcohol use because we are very much a drinking society, and the harms that come with that far outweigh a lot of the positives. And that's not to say that I don't enjoy a good bourbon or a glass of wine from time to time, but when you're young, moderation usually isn't on the foremost of your mind. And I think from like a harm reduction perspective, when you're in college, kicking back with a little bit of cannabis is far more beneficial than over consuming alcohol.
Well, I mean, it's true. Alcohol is so mainstreamed in our society, and cannabis up until recently has been demonized. And it's unfortunate because, I'd say I've been a doctor now for 47 years. And the number of patients I've admitted to the hospital with side effects related to cannabis was absolutely one. When I was an intern at Kaiser who had cannabis that was laced with PCP.
Oh.
The number of patients I've admitted to the hospital with complications of alcohol use are too numerous to count. So, it's funny how we are. I think economics are involved somewhere along the line.
Absolutely. I also think that that's really indicative of the trend that we're seeing now, where people who either haven't used cannabis for a while, have never used cannabis, or are kind of curious are now starting to experiment with cannabis drinks because it's a familiar format because of our drinking society. And I wonder I'm wondering, I'm excited to see when white papers start to come out about that and see how that influences society and people's health.
Yeah, I haven't been aware too much of that delivery system.
Yeah, it's getting more and more popular. I think we'll start having more conversations in the future about that. But that aside, you entered medicine at a time when cancer care was very different than it is today. What shaped your early approach to treating patients with life-threatening illness?
With life-threatening illness?
Mm-hmm.
Yeah. So first of all, how did I get into that? At Kaiser, when I was an intern and a resident, the patients that resonated and spoke to me most loudly were those who were dying. And, when I chose to go into oncology, I think it was to help me cope with fear of losing people that I loved. From my birth to my second birthday, 3 of my 4 grandparents died. And my mother was 22 when I was born, so 24 when she was orphaned. And I really feel that as a somewhat neurotic Jewish mother, she must have vibrated into me fear of losing people that I love. So, during my training to be an oncologist, suddenly AIDS came out of the blue. And that really dictated much of my growth as a physician, because I was a young gay man learning about cancer, and here suddenly I was faced with my contemporaries, my people, dying of a terrible, terrible disease that we knew nothing about, really. So I forget what the question was, but I hope I'm getting close to answering it.
Yeah, well, I think I'm actually going to rephrase it. How did you develop your approach in your work? And I think that what you've just said really illustrates that in many ways. Being like, I started my career in cannabis after cancer, and before that I worked in civil rights. So starting my career in the Castro was a very poignant, very historic moment, because I made friends with and met a lot of people that are still in my life today that lived through that time. And hearing their stories about how, they lost friends, or finding that cannabis was helping their friends eat and therefore survive, but having to get into precarious, possibly dangerous situations to procure it for their friends, was deeply impactful for me as well. And I'm wondering, because your bravery around having the conversations of using it for symptom management and helping people, and your research was a very big deal. How did you find the strength to work against the stigma and be able to hold the space as a professional? Because you're a highly regarded, highly respected physician. And so you brought great dignity and seriousness to the medicinal applications of cannabis. How did you navigate that?
Well, again, I experienced cannabis, so I knew what it was and what it did and what it didn't do.
Mm-hmm.
Again, as I said, it was my substance of choice through medical school and even undergraduate. And then, not untouched by AIDS myself, I lost 4 partners, men that I lived with from age 25 to 39. All of them are dead. The last one died while we were together. And he was somebody who used cannabis quite a lot. And he died in 1989. AZT became available in 1986 as the first useful AIDS substance that I didn't believe in. So he never took it. And he outlived 3 support groups at Davies of men who all took AZT, and he didn't take AZT. He smoked marijuana. And in 1992, Mary Rathbun was arrested for making brownies and bringing them to our patients at San Francisco General Hospital AIDS program. Mary was an older woman who lost her only daughter in a traffic accident to a drunk driver. So she's very much anti-alcohol, but very pro-cannabis. And she would bake cannabis brownies for our patients at San Francisco General and bring them. She was volunteer of the year for 2 years running. She would take our patient's prescription to the pharmacy and wheel the patients to X-ray, and she would also give them brownies. 1992, I was in Amsterdam, of all places, at the International AIDS Conference, and I was glancing at CNN headline news, and there was Mary being arrested for baking brownies. I said, what? So I got home, and Mark Jacobson, one of my colleagues at San Francisco General, brought me a letter. He said, you might be interested in this. At that time, I was leading a group called the Community Consortium, doctors in the community that were doing research in their offices. And the letter was from Rick Doblin, the president of MAPS, the Multidisciplinary Association for Psychedelic Studies, addressed to the director of research at the AIDS program at San Francisco General, which I wasn't, but Mark brought me the letter saying, you might be interested in this. And Rick suggested that a clinical trial showing the benefits of marijuana should come from Brownie Mary's institution, as if she were our dean. And so I picked up the gauntlet and said, okay, let's see what we can do. Little did I know how it would take me 5 years to get marijuana and approval from the government to do a clinical trial. But, I said, each time a barrier was put up in front of me, I decided I needed to get over it. And ultimately, I got $1 million and 1,400 of NIDA's best cannabis cigarettes from the National Institute on Drug Abuse to do research on patients with HIV.
How did that go about? Like when you were looking at, I know, you understand research protocols, but how were you able to warm people up to the idea of getting into this kind of research? I mean, San Francisco is known for being more open-minded and liberal, but that's very different than a healthcare institution.
Yeah. First of all, what I learned during the course of my 5 years trying to study cannabis as a possible aid to patients living with the AIDS wasting syndrome was that NIDA, the National Institute on Drug Abuse, was the only legal source of cannabis at that time for research. And NIDA has a congressional mandate that they can only study substances of abuse as substances of abuse. So my requests to study the potential health benefits of cannabis were not going to go anywhere. In 1996, protease inhibitors became available as really the turnaround drugs for patients living with HIV. Protease inhibitors, however, were exquisitely metabolized by the liver enzymes that were impacted by other pharmaceuticals as well as recreational substances. So doing a quick check on the metabolism of cannabis, I realized that I could present to the government a study saying I wanted to see if it was safe for patients with HIV on protease inhibitors to inhale cannabis. And as long as I was looking for potential harm, I was able to get funding and cannabis from the government. So that was the beginning of my cannabis research career. And, we did it because, as you mentioned, the early drugs for HIV were not very well tolerated. People got nausea and they liked cannabis. Cannabis was useful for nausea. And we know that it is, even though, there aren't that many randomized placebo-controlled clinical trials of cannabis for the reason that I mentioned. It is still Schedule 1, although I think he just signed something to make it Schedule 3. But for my career, cannabis has been a Schedule 1 substance, which means high potential for abuse and no accepted medical use. And you have to get a special license from the government to be able to even do research on it, to be able to, give it to patients in a research setting. So, so it was quite an adventure trying to do that first study. In 1999, the state of California had a budget surplus. So with that surplus, Senator John Vasconcellos, may he rest in peace, established a Center for Medicinal Cannabis Research at the University of California, the purpose of which was to be able to fund clinical trials looking for the potential health benefits of cannabis as opposed to the detriment. And originally I was on the board of the Center for Medicinal Cannabis Research, which is located at UC San Diego. But I said, you know what, I want funding, so I can't be a board member. So I left the board and became an applicant for funds and got a number of clinical trials funded by the Center for Medicinal Cannabis Research.
That's fascinating. The work that you did with research really paved the way for other researchers to figure out what lens they had to direct their research to get funding and to actually create movement. I know for myself, my mother being a hematology oncology nurse and cancer researcher, she'll tell you that she never told me to use cannabis during chemo when I went through FOLFOX5 because I was stage 3 colon.
Yeah.
Yeah, but she'll say
Yeah.
she said, I told you THC would be good for nausea, not cannabis. She's always very careful. But the one thing I learned was when she was doing research at Baylor in Dallas, I would get hooked up on a Wednesday and take my little pack home with me on a Friday. My nurse would come and unhook me on Fridays. I used cannabis for nausea because using like the opiates for pain or using some of the antiemetics would cause constipation, which was really dangerous for my condition. So I would use cannabis during that time. But on Fridays after I got unhooked, I would hop on a plane to go spend time with my mom in Dallas. And of course, I was really nervous about traveling with anything because you're in federal airspace. So that was the time that I tried Marinol one weekend. And I have to say, it was a really awful experience. Still smoking joints? Okay, we need to talk. If you love cannabis but you're still lighting it, let's look at what's actually happening. When you burn flower, you're creating smoke, and that smoke contains harmful compounds like tar, soot, benzene, and formaldehyde. In fact, almost 200 different compounds have been detected in joint smoke. So how do we know this? PAX decided to study it. In controlled lab testing, they compared joint smoke to vapor from their devices, using the same flower under the same conditions and measured 16 key harmful compounds. The result is pretty striking. Vaporization reduced those compounds by more than 95%, because when you heat cannabis instead of burning it, you change what you inhale. You still get cannabinoids and flavor, just without all the extra stuff that comes from smoke. This isn't about judgment, it's about information. If you want to learn more, go to pax.com/science. Pax is setting higher standards so you can smoke less smoke. And for Planted listeners, get 20% off at pax.com with code PLANTED20.
Yeah, well, I think the plant, nature did it best. The plant is the best medicine. In that first trial that we did to see if it was safe for patients to smoke marijuana while they're on protease inhibitors, the other arms were dronabinol, the Marinol, 2.5 milligrams, 3 times a day, or placebo dronabinol. And the patients were in our clinical research center at San Francisco General Hospital for 25 days, smoking or taking the pills for 21 of those days. And I'll tell you, it was so evident who was on the dronabinol versus who was on the placebo, because those dronabinol patients were in bed like almost 24/7, whereas the marijuana people were up cleaning their room and dancing in the hallways, and the placebo patients were relatively unaffected. So yeah, dronabinol was licensed and approved in 1986 for treatment of chemotherapy-induced nausea and vomiting. Well, why did anybody think to look at delta-9 THC? Well, in the 1980s and late 70s, Jimmy Carter was president, and cannabis was a little bit more, sort of okay. And young people getting young people cancers, testicular and Hodgkin's disease, still treated with the same aggressive chemotherapy regimens now that we used back then, but they were highly nauseating. And our young patients said, you know what? Marijuana works better than your licensed and approved prochlorperazine, which was pretty much all that was available. So that's what led the pharmaceutical company and the National Cancer Institute to look at delta-9 THC, which ultimately was licensed and approved. Up until 1992, the federal government was supplying a handful of patients with 300 cannabis cigarettes a month. These patients had so-called orphan diseases, and it was felt that even though the government said no accepted medical use, that these patients benefited from cannabis. So 1992 was still a dark period for AIDS patients because treatment hadn't come about. So the government was afraid that AIDS patients, numbering thousands or tens of thousands, were going to say, we have an orphan disease in the AIDS wasting syndrome, and they were going to demand 300 cannabis cigarettes a month, which the government could not have supplied. So in 1992, Bush II closed the so-called compassionate use program, and the FDA expanded the indication for dronabinol to include treatment of anorexia associated with AIDS wasting. Well, what's anorexia? Loss of appetite. The study, placebo-controlled study, did not show that those patients gained weight. but their appetite improved, and the government, just to have a way of saying, you don't need our cigarettes, here's your marijuana, expanded the approval of Delta 9 THC for anorexia associated with AIDS wasting. So that's when I first started to prescribe it. I never used it in cancer patients. And patients said, forget it, Donald, I'm going to smoke marijuana. This is way too much. I think the plant has a good balance of cannabinoids, those 21 carbon terpenophenolic compounds that are THC, CBD, CBN, CBG, et cetera, as well as flavonoids and terpenoids. All of those have medicinal benefit, and they all balance each other. And if you just take one, the most psychoactive component out and isolate it from everything else, it's a very different medicine.
Yeah, we're still making that same mistake today, I believe, in the cannabis industry, where we're so concerned with THC percentages rather than all the other molecules that create the entourage effect.
Or just taking out CBD.
Yeah.
Making that a $23 billion industry in the absence of any evidence that it really does much, in my opinion. Yeah.
Right, that's it. Yeah, I saw a lot of that, especially in the beginning of the boom with CBD. And some people would attend my classes that were getting into some of the multi-level marketing schemes. I actually had a group of people who came up to me after class and said, we are is CBD the seed or the plant? And that's when I found out after that they were actually starting a CBD business. And I thought, wow, I think we're in a little bit of trouble here.
Yeah, it's definitely taken off.
Yeah, it has. But, in retrospect, when I think about, the government grown cannabis and hearing about how badly it was stored and the chance that there were molds, mildews, and funguses in it, perhaps with people with compromised immune systems, it was for the best that they didn't have access to that plant material and that they had to get it from a good farmer in California instead.
Yeah. I don't know. It wasn't so terrible. It was just, we like the flower. That's the highest concentration of the main medicinal qualities are in the trichomes on the flower. And I don't think I ever really got flower. I got mainly sticks and seeds and, leaves. But
Right.
yeah, it wasn't the best quality, but it worked. I mean, the clinical trials I did demonstrate benefit when I was looking for benefit, and so it wasn't so terrible.
Yeah.
Now I don't know. I'm happy I did my research when I did it using NIDA's sort of limited access of agents, because now who would know what to study? There are so many different options out there that I don't know how to go about figuring out what should be studied. But your point about constipation from the conventional anti-nausea medicines that oncologists prescribe is really important, because still to this day I see patients who say that they don't want to take the ondansetron because it's so constipating. They prefer to treat their chemotherapy-induced nausea with cannabis.
Yeah.
And it works for some people. It doesn't work for everybody, but if it works, and then you still get to move your bowels. So that's a good thing.
Yeah, it is. And I mean, and it's the anti-nausea drugs are extraordinarily expensive. I'll tell you what, I can say this now since it's been a long time. I used to get the prescription filled anyway because I had fellow patients that would not use cannabis but couldn't afford their anti-nausea. So I used to give it to them. I'd fill it and I would give it to them because it was one of the biggest things my mother used to get so upset about when she ran a hem-onc office, was, the pharmaceutical salespeople coming in and bringing all sorts of swag and stuff to her staff. And she was like, you doing this makes these drugs expensive for my patients. And I don't appreciate that.
Yeah. But in addition to nausea, I mean, I see patients, of course, who have pain.
Right.
And I think cannabis is useful for pain, especially you can lower your dose of opiates if you're using cannabis in conjunction with opiate analgesics. Cannabis is good for sleep. I still think it's the whole plant that's good for sleep, especially if it's indica and, maybe has a little bit of CBN in it. Anxiety and depression, some people have adverse reactions, get paranoid or more depressed, but other people get, their mood lifted. I mean, I think we live in a euphoriophobic society where we think, we're Judeo-Christian, uh, developed by the Puritans, and we don't like people being high or happy. But it's not a bad thing, especially if you have cancer or another terminal disease. So, you know, one drug, and cannabis is the only anti-nausea medicine that also increases appetite. So appetite, nausea, pain, insomnia, anxiety, and depression. I mean, a traditional doctor could write prescriptions for 5 or 6 different medicines that would all potentially interact with each other or with the cancer therapy that the patient's getting, whereas I can recommend one botanical.
That's nice. That's really nice. Now, do you ever have patients who ask you if cannabis is going to interact with their treatment? Are they concerned about that?
Yeah, I mean, I've done 2 pharmacokinetic interaction studies. The one with the protease inhibitors, we measured the level of protease inhibitors in the patient's drug when they were smoking or taking the dronabinol. And then I did a pharmacokinetic interaction study between vaporized cannabis and opiates, sustained release morphine and sustained release oxycodone. And in all of those studies, I never saw a clinically significant alteration of the blood level of the other drug when patients were using cannabis. So I think, there's potential, but I don't think, especially if you're inhaling it, it's not likely to have a huge effect. Now, when patients are taking highly concentrated oils, which were popular a few years back for so-called treatment of the cancer, highly concentrated oils of either THC, CBD, or the plant itself, then I worry about possibly interfering with the standard anti-cancer therapy that the patients are getting, just because the concentration of the constituents is so high in an oil like that.
Yeah, and then you're dealing with the pass-through of the liver, and in the case of oral CBD, you could be looking at a cytochrome P450 interaction.
Exactly. Yeah, that's the mechanism that makes the level of the drugs increase in the bloodstream. Particularly CBD is more of an inhibitor of that system. And personally, I think that's how CBD might work for seizures in those young children with seizure disorders, that it actually was increasing the concentration of their prescription anti-seizure medicine.
That's fascinating.
Yeah, I read that in an editorial in an epilepsy magazine many years ago. It does do that, and I've seen patients taking highly concentrated CBD preparations that may have made some of their pharmaceuticals more toxic that way.
Yeah, I could see where that would be. And that's actually, something that when back, especially back in the 215 days, or in times when I would have physicians referring their patients to me to talk about cannabis, because a lot of doctors still don't understand that much about it. One of the things that I always tell them is, I'm not a healthcare provider. I can only help you navigate and figure out what works well for you and give you information so that you can talk to your physician about it. But physicians say over and over again that when their patients tell them about their experiences and what they're using and how it's turning out, it not only helps them keep an eye on them with, certain pharmaceuticals that they're on, but they also learn a lot so that they can help their patients as well. And it's just so incredibly important for people to talk to their doctors about their cannabis use.
Sure. My friend and colleague, Ilana Braun at Harvard, did a survey of 400 oncologists responded. And out of the 400 oncologists, 80% said that they talked to their patients about cannabis. 78% said that those conversations were patient initiated. 67% thought cannabis was useful in the treatment of pain. 67% thought it was useful for appetite and weight gain. Less than 50% ever recommended it, and only 30% felt that they knew enough about it to talk about it. So, with the new deregulation of cannabis to Schedule 3, my concern is that this is a useful botanical that's been around for 3,000 years, and it's really quite harmless compared to many other prescription drugs that we recommend. And I think as a botanical, it should be available to patients like echinacea and turmeric, but regulated like tobacco and alcohol. And I don't think we need to interpose a physician between the patient and their medicine, personally.
Yeah, I mean, I think it's just good for you to have a good relationship with your doctor so you can just tell them what you're using, just like you would. Hey, I'm using turmeric, I'm using echinacea, integratively, what are your thoughts on this? And that would be real. That's something that I feel like really lucky that I've had with my doctors, is being able to have those conversations, because there's trust and safety in that.
Yeah, well, I mean, just today I was doing a clinic here this morning where I do my integrative oncology, and I have access to the medical record, and I say, let me review what you're taking as far as medications and supplements. So the first patient was a new patient, and I said, oh, after going through 5 or 6 prescription meds, I say, you don't take any supplements? And he said, oh, of course I do. But they weren't in the chart. Even when I went to my own doctor and, they sent me my list of medications that were in the medical record. And I said, when I got there, I said, well, I'm not taking this prescription med anymore. I did add this one, remember, and my supplements are not correct. And so I started going through it. He said, let's just keep it simple. He didn't want to hear about all my supplements. He didn't want to have to put them in because most of the time they're not on the drop down menu. So, yeah. So you have to know how to ask the question,
Yeah.
and you have to take the time to insert it because it's important.
Hey guys, Hirsch Jane from Humboldt Family Farms here. And I gotta tell you about my dispensary run this week. It's my regular spot, right around the corner. There's a whole wall of flour, good prices, plenty to choose from. And there's not one sun-grown brand in the place. That bugs me. Sun-grown is how weed's been grown since forever, out in the dirt, under the actual sun. Sun-grown cannabis cures slower, it builds terpenes, and it does it on rainwater and sunlight instead of a warehouse of grow lights and AC. But it's scarcer on shelves these days because stores chase price and THC numbers, and sun-grown gets squeezed out before you ever get to try it. That's why we started Humboldt Family Farms. We're a collective of independent family farms up in Humboldt who've worked the same ground for decades, and we get their sun-grown flower onto shelves with their name still on it. So ask your shop for what they've got that's sun-grown. If the answer is nothing, you already know what to ask for.
Yeah, it is important. And I think that's why it's really important for patients to find a good fit with their doctors too. Somebody who shares their ethos around that, if that's something that they're into. I'm wondering, when we're talking about things like Marinol, but then the possible rescheduling to Schedule 3 that this administration has advocated for. We see some products on the market now, Epidiolex and Sativex, but it seems like they're kind of still leaning on just the one molecule rather than looking at the whole plant. What do you see? And I know it's hard to predict, but do you think that will continue just with big pharma's way of wanting to patent things and just lean on pat answers instead of getting into the nuance?
Yeah, I mean, nobody's going to patent marijuana. I mean, it's out there. It's a plant. So the pharmaceutical industry has to be creative. Epidiolex is just CBD, cannabidiol. But Sativex, my understanding, it's not available in this country, but it's available around the world for treatment of spasticity associated with multiple sclerosis. And that is a whole plant extract. It's just been modulated to have a 1-to-1 ratio of THC to CBD. But I believe it has other compounds in it as well. Yeah, I mean, the one cannabinoid that I think might be interesting to develop as a pharmaceutical is tetrahydrocannabivirine, or THCV, because apparently it decreases appetite for food, for alcohol, and perhaps for opiates. So, that is something that our society could probably use if it really pans out to have all those potential benefits. But yeah, I'm sort of against isolated cannabinoids or terpenes. I think nature did it best. The plant is the medicine.
Yeah, I completely agree. We've been hearing more about CBC. Have you done any work with that at all?
CB which?
CBC?
What, the last letter? I'm still
C as in cat.
CBC. No, I don't. I haven't heard that one. CBG, CBN, CBD. I don't know about CBC. What is that good for?
So CBC, they're talking about using it for pain, also for mood. And they're saying that there are some studies that are starting to come out about CBC and cancer as well. I mean, working in a dispensary and, being a cancer survivor myself, I would always hear about, things with Rick Simpson and stuff like that. And of course, I always looked at it as I totally believe in it for symptom management. But when we talk about cannabinoids curing cancer, like sometimes in the beginning of my career, when I would go to conferences, people would introduce me as the girl who cured her cancer with cannabis. And I would look at them and I'd say, my mother would turn white if she heard you say that. If I could have foregone all the chemo and the resectioning, you're darn right I would. But, where the jury is still out on that. And it just seems like it kind of comes out with when anyone ever gets critically ill, people with some of them with the best of intentions come out of the woodwork with all these magic beans to sell you when you're sick. And I feel like we really have to be careful about making cannabis not part of that equation.
Yeah, well, I mean, what happened, the CBC effect against cancer, I imagine, is in the test tube and not in people.
Right.
And a very wonderful book is Raza Azra's book, The First Cell. She's a hemato-oncologist whose husband actually was a very famous oncologist, studied lymphoma and died of lymphoma. But in her book, she points out that only 5% of all substances which are studied in the test tube and in animals as anti-cancer therapies make it to the market as something that's useful in human beings. And that's because what happens in the test tube does not often translate into what happens in people. People are much more complicated than test tubes and even mice. And when I was an AIDS doctor, I used to tell people that soap suds and gasoline work against the virus, but I wouldn't recommend either one of them as a treatment. Right. So, all of these things working. I mean, it was 1975, investigators at Virginia Commonwealth University first demonstrated that the THC and Delta 8, Delta 9 THC were effective against cancer cells in the test tube. And CBD actually did the opposite. It made them grow more. But that research went off the shores across the Atlantic, and most of it is done now in Spain and Italy, where there is evidence in the test tube and in animal models that cannabinoids may have some anti-cancer effect, but hasn't translated into people as far as I can see yet.
Right. Yeah, because I remember Dr. Cristina Sanchez took some of the first pictures of THC creating apoptosis in cancer cells. And for those listening, that's natural cell death. But it is weird because I had a compassion program for many years where I would get free cannabis to our critically and chronically ill community members. And there was a woman who came in. She had endometrial cancer, and for some reason, she couldn't do the traditional treatments due to a heart issue that she had. And she came in on 4/20 of all days, her very first day, and she was crouched over in pain. And her family had given her money to try cannabis to alleviate the pain, but she didn't want to get high. So I took out a syringe of 18-1 because I said, you want to gauge how you react and you don't want euphoric effects. So we parsed it out so that it would be good enough for a week's use. And she came in the next time and she was standing upright and she's like, it was really helpful. So I ended up being able to source that for her. 6 months later, she came in and she said, guess what? My doctor said, I don't know what you're doing, but for the first time, things are looking better, so keep doing it. And I said, that's an anomaly. I don't know what that is, but, follow your doctor's orders. And then 6 months later, she came in and said, Now my doctor's saying, hey, how about if we see each other just once a year? And you and I both know what a big deal that is.
Yeah, that's a big deal.
And so she was, for whatever reason, that ratio with her body chemistry and her type of cancer was creating some sort of a change, because when that was right around the time that legalization hit and we all had to shut down our compassion programs because they didn't have that in Prop 64. And we had, as activists, we had to do work to get that allowed again. But what happened was she didn't end up getting access to the oil that she needed because she was on a very fixed income. And it ended up coming back full force, and she ended up passing from it. And for me, like, it doesn't mean that necessarily, it's not a broad stroke thing. It's not I see the possibilities, but I also see that as a conversation around the fact that we do need to do the clinical trials. And like you've said, human beings are all very different. I mean, I'm sure you've seen how different people react to different types of chemotherapies. I mean, I myself, the only thing that they say that I'm allergic to is oxaliplatin, because it almost killed me twice because I went into anaphylaxis. But, it's like, I think that's why we have to be really careful about the conversations. We hear very hopeful stories of real people, but amongst all of that, there are so many people who tried as a last resort and may not be and probably aren't working with researchers doing clinical trials. And so they spend a lot of money and they end up just getting overly high and having very tragic outcomes.
Yeah. You mentioned oxaliplatin a few times. Did you develop neuropathy from your treatment? Because people on cannabis, usually, an Israeli study looked at 580 patients getting Folfox, which is what you got, and half of them used cannabis, and they chose an equal number of controls who didn't use cannabis. In Israel, if you get access to cannabis, you get a license, and that allows them to ask you questions and survey you them, and doing research on observational use. And amongst the patients who used cannabis during their chemo, half of them started cannabis before they got the oxaliplatin, which can cause nerve damage, and the other half started after they got the oxaliplatin. And what they found was patients who were using cannabis before they got the chemo had much less severe peripheral neuropathy or damage to their nerves from the oxaliplatin compared to the people that started after, or the people that didn't use it at all. And in fact, the people that started cannabis before their chemo were able to get more chemo because they didn't have to have dose reductions because of the neuropathy. So I think, cannabis as a useful adjunct to chemotherapy. I don't think it cures cancer. I say, I've been an oncologist in San Francisco for 43 years, and I'd venture to say that probably 50% of the cancer patients that I've treated have used cannabis in one form or another. And if cannabis cured cancer, I'd have a lot more survivors.
Yeah, absolutely. Yeah, I still have peripheral neuropathy. And I was told that by my third round, I would start to experience neuropathy. But my very first round, I had a hard time drinking room temperature water. So I was I was just more sensitive. But when you're mentioning that reminds me of in 2015, I was part of the faculty for Patients Out of Time. And some of that research was presented, and they were talking about using a CBD ratio before, during, and after treatment. And so when I came back to San Francisco, when I would have patients that were going to be going through chemo where they may have neuropathy, I would say, I can't give you advice, but this is what I learned at this conference, and you might want to talk to your doctor and see if it makes sense. And I got a lot of reports back from patients saying that either they experienced neuropathy way later in the cycle, they bounced back faster, and some of them didn't experience it at all, which I wish I would have known that, because we weren't even talking about CBD when I went through treatment. But there's also THC involved as well.
Yeah, I would think so. Yeah.
Yeah. But I mean, that's the thing I think I love about, working with cannabis, is that we're constantly learning new things. Things are constantly being disproved, but we also have to have a lot of conversations to create the balance, because it's not a panacea, but it's certainly shouldn't be demonized the way it has in the past either. We have to be really realistic about what it can and can't do and what the possibilities are for the future when we get access to better research.
Are you looking for a lasting, meaningful way to connect with your audience and highlight your brand? Well, listen up, because Planted with Sara Payan is taking on new sponsors. Here's a powerful stat. 20% of listeners are more likely to support brands they hear about on a trusted podcast. And 60% actually look up that product after hearing about it. That's the power of podcasting. Planted with Sara Payan has a unique draw. With remarkable guests, we attract and engage audience that spans all sides of the cannabis spectrum. Picture your message reaching these listeners time and again. Podcast ads are evergreen, meaning your brand stays relevant as new audiences discover and binge past episodes. It's a long-term investment that keeps on giving. If you're looking for a targeted, passionate audience with lasting impact, the right listeners are here waiting to meet your brand. Visit plantedwithsara.com to get a copy of our sponsorship deck today.
Yeah. Well, I mean, even without having access, the number of cancer patients using cannabis is definitely not insignificant.
Yeah.
I just, this month, I believe, the Society for Integrative Oncology is producing a new textbook on integrative oncology. Andrew Weil and I edited the first integrative oncology text from Oxford University Press in 2009, and we did a second edition in 2014, but we haven't touched it since. So it's about time to have a new textbook. And I retired actually 6 years ago now, but I still work a little bit, but I don't like to write anymore. But when they asked me from the Society for Integrative Oncology if I would write the chapter on cannabis and cannabinoids in cancer, how could I say no?
Yeah. Well, what are some of the things that excite you about the work that really draw you in intellectually?
Well, I mean, I am curious to understand if there is any evidence that cannabis can do anything for any cancer. I mean, my friend and colleague Manuel Guzman at Complutense University in Madrid really has done the most elegant work. His laboratory studies the effect of cannabis on metabolism, and the brain is the most metabolically active cells in the body. So they grow up mouse brain and they add cannabis to see what happens. And they said, maybe we could do this faster if we grew up a mouse brain tumor. So they grew up a glioma and they added cannabis and everything died. So they said, oh, we must have done something wrong. So they did it again and everything died. They said, maybe it's a bad batch of cannabis. So they went back to normal brain and everything lived. So since that time, as you said, they've decided that cannabis, when it complexes with the cannabinoid receptor in the brain tumor, it induces programmed cell death. And they've also demonstrated that cannabis reduces vascular endothelial growth factor, which allows new blood vessels to form to feed a tumor. And that's what a very expensive medicine that we use all the time in cancer does, bevacizumab or Avastin. They also demonstrated that cannabis blocks something called matrix metalloproteinase 2, which allows cancer cells to become aggressive and metastasize. So, I mean, that all happens in their cell cultures, and now they're trying to take that into human studies. And of course, the first thing that was studied was glioblastoma, the most aggressive brain tumor, because of this evidence that, that cannabis seems to work in the test tube. And there's some, signals of evidence that it may be. But the problem is that one study that I always wanted to do, but somebody else did, was looking at tumor specimens. We look at genetics now and look for mutations. And I think we should look for cannabinoid receptor expression, CB1 and CB2, on all tumors. And they've done that now, and they find across the board that there's nothing consistent. Dudi Meiri's group in Israel looked at 12 different tumor cell lines in the test tube and added cannabinoids. And they found that the plant-derived worked much better than the individual cannabinoids. but they found that this prostate cancer cell line responded to this extract, but not that one. And the prostate cancer cell line next to it didn't respond at all. So it's a little bit disconcerting that there isn't, something straightforward that we can really tease out. So I'm not sure how many people are doing that sort of research anymore. The other thing that's very, to me, a little bit confusing, again, the Israelis, because they have this system where they can study things, have suggested that patients who use cannabis while they're getting immunotherapy, which is very popular now, the treatments that we use to unleash the immune system to fight against the cancer, they found that their survival is on average 2 years less than patients who don't use cannabis during immunotherapy. And that was found in 2 different clinical trials in Israel. They're not prospective randomized placebo controlled. They're observational, looking back and showing that those patients that did use, well, maybe they used cannabis because their disease was more progressed at the beginning. And in one study, the patients who used cannabis were more likely to have brain or liver lesions as opposed to the people that didn't. So that's one of the problems of observational study, that you can't really control for the differences between the group that uses something and the group that doesn't. But now there's more prospective data showing that patients who use cannabis with immunotherapy don't really have any survival difference. So right now, for me, that's something that I'm confused about. And when I talk to patients on immunotherapy, I say, maybe, you should sort of cut back on the cannabis now. And I show them the graphs from the Israeli studies, which are very dramatic difference in survival.
Yeah. Yeah, that's fascinating. But I mean, that also shows that, it's not a panacea. We're all really different. It depends on what we're going through. But, one question that I had for you was, oh gosh, I just blanked out. And it was like right on the tip of my tongue.
Oh, you lost your question.
I lost my question. Give me one sec here. We were talking about that.
Immunotherapy.
Okay, I'm just going to forget it. It'll come back. What are, I mean, when we look at that, I mean, it just shows that, we have to have a very open-minded, nuanced approach. Oh, I know what the question was going to be. So we see a lot of clickbait in the news these days about all these different things, these bad things that will happen if we consume cannabis, especially like with the heart and different things like that. What are your thoughts on that?
I think it's Reefer Madness 2026. I think because it's out of the bag, I think there are, I don't want to get paranoid, but what about the alcohol industry? I mean, they're getting nervous because, more people are smoking and using cannabis than consuming alcohol. But, that study that came out that you're mentioning about the heart attacks, if you look very carefully I took a picture of it and I have it on my phone. In the methods section where they showed that the people using cannabis had this many times more heart attacks, they said the event rate was very low altogether. So meaning that, 2 times 1 is 2. So, it's not like you're going to die, tomorrow. And Clint, my husband, Clint Werner, wrote Marijuana Gateway to Health, How Cannabis Protects Us from Cancer and Alzheimer's. And he's a pretty professional stoner. And he said, how many people do we know that are using cannabis regularly? Do we know anybody who's ever had a heart attack or a stroke? No, only Dennis Perone, because he also smoked cigarettes. So, it's all obfuscated. And, the lung cancer, whatever. I mean, Don Tashkin, a friend and colleague at UCLA, was funded for over 40 years by NIDA to look at the pulmonary effects of cannabis smoking. And he said, if you're using anything like that to keep it illegal, you don't have a leg to stand on. Because he
Yeah.
actually found that the only thing was increased cough and bronchitis, but actually found in one large study of 1,500 people in the Los Angeles basin that people who use cannabis lightly had less lung cancer than people who didn't use cannabis at all. So,
That's
yeah. So
fascinating.
I think, now we're sort of in a reverse tidal wave of negative, propaganda, sort of like reefer madness, I think, because, cannabis is becoming more mainstream than it used to be, and people are nervous and want to turn it around.
Yeah, well, it takes money away from some big business that can do some great harm, and it's I
Tobacco as well, right? As well as, yeah.
absolutely. I mean, that's a call for critical thought for people to, instead of looking at headlines, really dig deep and read what's written, because it's not always, the headline isn't always what's in the body of the work.
Yeah, I mean, even UCSF magazine put out something about, and I got in touch with the editor in chief and I said, "What are you talking about?" I'm embarrassed that here I am at a university that now only focuses on the harm. I stopped doing my research when I retired, and now the cannabis group is part of the old tobacco regulatory group, and so they're not looking for benefits of tobacco. They're not looking for benefits of cannabis. So it's a little bit disconcerting to me that my home campus is spreading a lot of this information that to frighten people.
Yeah. Do you think that in many ways research is very influenced by trends?
By trends,
By trends. I mean, when we see this trend of
well,
anti-cannabis rhetoric.
nowadays it's hard to know what influences research because I just went to a oncology research conference at UCSF last week, and listening to my younger colleagues talk about the difficulties they're having obtaining funding to do research from the federal government was really alarming and made me very happy that I'm retired.
Yeah, for
Yeah,
sure. Well,
I don't know. Yeah.
and on that note, what are you excited and hopeful for?
What I'm saying
What
again?
are you excited and hopeful for?
Well, I mean, again, the down scheduling of cannabis to Schedule 3, should I be excited about that? As I mentioned, I would prefer for it to be descheduled and not, but let's see what happens with that. I mean, I know that people in the industry are concerned because if it's Schedule 3, does that mean it's going to only be available through pharmacies now, or is it still going to be dispensaries? And, so I think excited to see what's going to happen, whether it's a positive excitement or a fearful excitement, I can't say at the moment.
Yeah. Yeah, I know. It's a wait and see sort of thing, and quite honestly, my view on it is it's who's got the money and who are they giving it to is where we're going to see the changes, and whether that's a good or bad thing is yet to be seen. Because politics these days are a very interesting thing. Not that they're not always interesting, but these days it seems like they're more interesting than ever.
Yeah, exactly.
Well, Dr. Abrams, thank you so much for joining me today. And for the record, I have Clint's book. It's a good one. It's a classic, and those of you out there, you should pick it up. For anybody who wants to check out your work, or just see some of the things that you're doing, is there a way for them to be able to do that?
Well, if you Google Abrams, Osher, Osher, I'm at the Osher Center for Integrative Health at the University of California, San Francisco. At the bottom of my webpage, I have a number of videos, including cannabis and cancer, what is integrative oncology, nutrition, other supplements. So it's a useful site.
Awesome. Thank you so much. It's been a pleasure talking with you. And thank you so much for all of the work that you've done, because it's made a huge impact, not only for access to patients, but also for the world to take this work much more seriously.
Thank you.
This episode is brought to you by Fat Nugs Magazine, a global perspective of cannabis and stoner culture as a bridge to the rest of the world. Right now, you can join Fat Nugs Magazine, Beard Bros Farms, Freedom Grow, and Jailed for Weed in the upcoming Prisoners Edition and help spotlight current and past cannabis prisoners and their stories, because no one should be in jail for a plant. Find Fat Nugs Magazine's beautiful print copies at your local dispensary, fatnugsmag.com, and on socials. Cannabis culture welcomes us all. And everyone, remember, if you like listening, please give us a review, share it with a friend, let us know what your favorite episodes are. And if you'd like to stay in touch over social media, we are Planted with Sara Payan on Facebook and Planted with Sara on Instagram and Twitter. You can also go to our website, www.plantedwithsara.com, or listen to us on our parent network, Radio Misfits Network, where there are other great podcasts, like one of my favorites, the Winemakers Podcast. So check it out. You can listen to Planted wherever you listen to your favorite podcasts, whether that's Pandora, Spotify, Amazon, Google, Apple, Stitcher. Tune in. We are there. So join us. And until next time, stay curious, stay safe, and remember, it's a wild world out there. Be good to one another. Until next time, take care.